Hello, my name is Cameron Sabat, and welcome to Cutting to the Case. I'm joined today by Dr. Elizabeth Ames, and she is a spine surgeon, a professor, and vice chair of education at the University of Vermont Larner College of Medicine. She serves as Residency Program Director for Orthopedic Surgery and coordinates the musculoskeletal curriculum with national leadership roles in medical education. Trained entirely at UVM with advanced spine fellowship training in Minneapolis, clinical focus spans degenerative diseases, deformity, trauma, tumors, and the osteoporotic spine. Thank you so much for joining us today.
My pleasure.
Of course. So I want to just kick things off in this little conversation with a kind of question tailored to your specific leadership role. What single decision as a residency program director most improved surgical judgment per graduating class, and why did it work?
So if I understand your question, you're asking me for a decision or a change that we made educationally that helped push forward towards competence in our graduates more than others. So obviously that's the goal all the time. Um, Believe it or not, despite the fact that I am an educator at heart, I've been a program director long enough to understand that the things that are the most important are very often not, sorry about that. There we go. Um, Things that are not actually curricular and that are more related to the system around you. So the two that come to mind immediately when you ask that are trying to or beginning to understand the faculty development needs of orthopedic surgeons to trickle down to our residents on the one hand. And the second is the biggest change is trying to adjust in my gray hair years to things like the unionization of our hospital system, the change. I'm a spine surgeon, and spine itself has become this little niche that actually crosses two specialties, not just one. Um, and then just I'm getting enough gray hair to feel a little old, if you will, relative. Things are not at all the same the way they were for my residents 10 years ago, to say nothing of 20 years ago when I started. So the most significant changes that I've made, I'll give you an example that's somewhat controversial for a lot of program directors, but it's shifting to a night float. You know, that was something that took a lot of time. It was not driven by the things you might think, like duty hours issues and, you know, mandates. It was driven by keeping our residents well and helping them understand and thrive in the situation they found themselves in. So, um, night float is counterintuitive in my world. You know, I'm old. That's not what you do, right? You don't. um, and trying to help any change like that, that's an earthquake in a residency. And in order to take people safely through an earthquake, both faculty and residents, you need to have a lot of planning, a lot of forward work, and a lot of, I'll just use the word political, and I don't mean that in a negative sense at all, but a little bit of horsepower in terms of understanding the folks around you. We're very fortunate in Vermont for that. We're a little bit of an island up here, but we have a great resident culture, and that has let me do things that might otherwise have been a major challenge for me.
Absolutely. And that's a beautiful example too. Something where it directly affects residents, and yet you have to work through the leadership, the hierarchies, the politics, I mean, it's such a complex approach.
And the
And
faculty. And the faculty,
yes,
the faculty are always very happy to say, "Oh, that's cool. I don't have to, my resident won't miss clinic because they're going home post call." Yeah, well, you now have an entire resident not in the rotation pool because they have to do this night float thing. So it was multifaceted. It took a long time, but we just had a meeting today where we talked about the next big changes coming, and our residents were like, "We don't want to lose night float," so I'll take that. anytime.
Yes, of course,
So,
of course. Yeah, I mean, you win some, you lose some. So,
absolutely.
yeah.
And sometimes, with the things going on right now that are things that none of us as program directors were educated about at all.
Mhm.
Whether as simple as competency-based education. I mean, I now have a degree that helps me understand that, but that's what I had to do. But if you think about the changes just in your time, from the time you started medical school to now, in the orthopedic world, specialty wise or business wise, it is not at all your father's Oldsmobile at all, as I'm fond of saying up here.
Yes, yes, of course. Thank you for sharing that. And, I wanted to also understand what kind of incentive structure inside academic medicine most impacts resident development and, you know,
Oof.
or distorts it or does something, and how do you counter that in terms of
So
institutional
you
culture?
talking, so do I need to put my hat on as a faculty member here or my hat on as a leader and program director? Because the answer might be slightly different.
Really interesting. I mean, I would be interested to see what you mean by that, actually. How it
Um,
would be different.
well, so let me put my faculty member hat on for a moment. And reminder, and to your audience, if you hadn't picked that up, I'm in the state of Vermont. And that there is a whole lot of political and financial mess in the state of Vermont. For those who are aware or not, take this, just take it as standing that our large academic hospital system, which is our only hospital system and our home, is it's just financially really, really tough in the state that, believe it or not, has the highest tax rate and one of the highest costs of living in the country. So there's this really weird stuff. As a faculty member, then you might imagine that the pressure is on for production. You as we like to say, 65 in fluorescent is where we make our money, despite the fact we live in the state of Vermont because we all want to be outside and it's beautiful. The weather is always the same in the operating room. And on top of that, we're very limited. To use another analogy, we were the last little state that was still green on the COVID map. And that was not because we're well ahead of the world. That is because we have 35 ICU beds in the entire state. So we had to be, and our governor did a fabulous job shutting us down for that because we couldn't handle the kind of things that we need to handle.
Mhm.
So, as an attending surgeon, the pressures here are to produce, and as I am fond of saying, keep the lights on in a way. All of us as physicians, not just orthopods, but all of us, really fight with the need to educate and the need to take time with a slow things down in the operating room to teach in the OR the way that you should. You know, the
Absolutely.
educational spin right now is to say, well, divide the case into parts and be clear with the pre-op plan for that part and bring me that, and that's what you're going to do, and this is what I'm going to do. And I don't disagree with that. I think there's some benefits to that.
Mhm.
However, in the end of the day, I want to know that my residents can go out and do a case from start to finish independently.
Mhm.
That's my job, right?
Yes.
And the more pressure is put on us as attendings to produce in an academic model that has to come from somewhere.
Mhm.
And it comes from time and if you're faced with a production goal that is difficult when you have to move cases through, that's really hard. Now, to be fair, complex spine surgeon, you know, 5, 6 hours, whatever. There's plenty of time to teach. Okay. But on the other hand, there's issues with reimbursement for everything. And our total joints populations across the country are certainly like that. Everyone is like that. We are all in academic medicine feeling a lot of pressure that makes it very difficult to meet educational goals.
Yes, yes. Competing demands from each direction. It really can feel like a juggling act. Yeah.
Absolutely.
You were talking about residents. I wanted to kind of pull on that idea a little bit. What skill do strong residents that you've seen in the OR consistently develop earlier than their peers?
Um, the global skill is self-directed learning, right? It's organization. I'm pretty sure there's a picture of my face with a dartboard on it somewhere that says, bring me a pre-op plan, because I probably say that 5,000 times in my 20 years. But, you know, self-directed learning has to be efficient, and in the pressures that you all face, that, and I'm not just talking about the rules about hours, I'm talking about just the practical reality of the amount of knowledge that orthopedic residents need to master in a pretty short period of time. You know, it was 5 years when I was a resident. It's 4.5. You know, it's 5 now. We were 4+1. Now it's 4+4.5 plus 1. Yeah, but the volume of knowledge is huge compared to what I learned. And there's only so many hours in the day. You know, so efficiency and self-directed learning, and a willingness to put that effort in despite fatigue, despite sometimes wellness issues, despite family conflict, despite trying to be a dad or a mom, you know, all those things is really, really hard. And I get that, but I don't have a solution for it necessarily. In
Yeah.
terms of specific technical skill, I think if you're self-directed, a lot of things like understanding, it's fairly easy at that point to understand the goals. And I personally believe the actual technical stuff is pretty easy to teach. We're fortunate in orthopedics that we have unbelievable pool of people who want to be residents. The problem is the picking which way to do what. That's the bridge between the two extremes. So that would be my answer. The hardest and biggest, most challenge is helping residents understand the why of the actual approach to that particular patient, and why that may not be the same approach to the next patient who looks exactly the same, has the same MRI, the same clinical symptom, but needs a totally different actual step-by-step approach.
Yes. Yes. And I also wanted to know, because we've been speaking a lot about the local culture, or I guess the culture you've produced in your own institution. I'm
Uh,
curious how your
let's
national
rephrase
work.
that. I don't say I produced it. I do think I benefit from it.
Yes,
How about
yes,
that?
yes. Um, the the culture at a local institution. And I wanted to know how your national work in medical education has influenced your local decision making here at UVM.
So that's a great question. And I think about that a lot. In fact, I think about that pretty much every time I'm on a plane between O'Hare and Burlington, which is a lot. Um, I think that I have been extremely lucky in some ways, because my national involvement, which started with taking the leadership of the orthopedic program directors group when it first, I was the third chair of that. So that was very early on, and then just growing from there. And it's been every few years, it's been a change to the next level, and to the next level, and to the next level, and to the next level. And so you grow that way, right? That's what we hope to do clinically, and I've had the really good fortune to do that in my professional life as an educator and a leader. I hope I have contributed, but I almost want to say I've probably learned more and brought more back to Vermont from that experience than I gave. Maybe. I hope they wouldn't say that entirely, but we just had a discussion today. We're redesigning now to adjust for more residents than we've had before. And the hard part about something like that is you need to look 5 years down the road or 10 years down the road to predict something you can't even begin to predict, because as we talked about, who knows, it's not like what it was. Having what my national work has done, both in my own specialty and now across 30 specialties, um, just helps look at how other institutions, other programs, even other specialties have gone about some of those things, and provides a little bit more of a broad base, or maybe a more open window
Mhm.
than I might have otherwise had.
Yes, yes.
as well as a fantastic group of people to call on when I need help. There is that.
Yeah, and you really do have a long-term view on all of this, and I think that's where your positionality in this specific role becomes very unique. And I'd be
Mm.
curious, when you look ahead 10 years, what change in orthopedic training feels inevitable? I'm sure there might be other program directors listening in on this conversation now.
Yeah. What, so, well, first of all, you're talking to a spine surgeon, okay? So whether you think it's good or bad, I mean, we just had this conversation at a meeting today at our place, you know, we actually have two residents going into spine fellowship next year, which is unusual. But, and the reason I say it's unusual is because, the majority of orthopedic graduates are never going to touch a spine after training. I have stood up nationally and said, I'm not sure why we're all so worried about 5 years turning to 6 years of residency, because when everyone is doing fellowships, we are a 6 year program. You need just that sixth year, whether it's for business reasons, which I think that's a fair discussion, but it's also sometimes just to learn the finer detail skill you need in the scope, in the whatever it is that you want to do in your career. And we have to respect that. So I think the biggest change coming, or I worry that the biggest change coming, is losing the generalist. And the reason I worry about that is because I am not sure in 10 years, the way things are going, when I put my Chicken Little hat on, uh, I think orthopedics is going to look very different. And I worry that the sort of high-end super specialist model, it may be very difficult to sustain in this country. On the other hand, if you look at Europe, they're doing very well with it. And that's my wish for myself, or my personal goal for myself now, is to take what I've learned and start investigating other countries, Australia, Europe. The way graduate medical education is done, there are a lot of people trying to do a lot of different things, and I don't think anybody has come up with the right solution yet. But if we don't start looking at the broader picture, what we're going to end up with is a lot of, you know, fill in the dot, fill in the paperwork, check the box, if you'd
Yes.
like, without any rationale or benefit. And in part, I personally believe that's how we got ourselves into this little bit of wellness challenge, and just plain old my generation. Um, what do we do? It's so different now. What do we do? But I love your question, because the heart of it is, what do I'm not old enough yet to completely hang up my shingle educationally. I am transitioning the program directorship over as I take on the vice chairmanship. So I'm I'm developing myself as well, just like you are. And what do where's the same thing that kind of really floated my boat when I realized that I wanted to do complex spine. That moment, how do I do that now when I think about education moving forward? A little bit of a different animal, but it shows
Yeah.
you you're never too old to slow down.
Yeah,
I'm not,
wow. I
I'm
mean,
not good at slowing down, apparently.
yes, yes, of course, of course. And there's this posture of developing yourself as well. It's really kind of impressive the amount of humility you have here. I mean, you've really trained so many people. I mean, you are the
I,
development. So, you know,
it's funny that you said that. Is we just completed our match list for next year. We were very early, so we're done with that process. And I realized that this is the 23rd
wow.
class. 23rd time I have been involved in creating a match list, and the 15th time formally as program director. And that's so we're only three until now. We've only been three, but that's still a lot of orthopedic surgeons out there.
Yeah.
And it would be great if someone would develop a way that we could get some feedback back, other than I track them down at meetings or they track me down or whatever. But, um, how did we do all that time? And where could we have done a better job? I think that's a question that all orthopedic surgeons ask themselves. And very often for us, myself included, and I don't mean this arrogantly, but usually it's like, but you're great. Of course, yes, we are great. That's what we do. We're orthopedic surgeons. You have to be great just to get the job,
Yeah,
right?
of course.
But we still all have places we'd like to get better. And I think so feedback is one of those grumpy words in orthopedic education, but the principle is not wrong. The principle is being able to provide direct information to help people who are self-motivated continue to get better.
Yes, yes. And I didn't want to interrupt you earlier on this conversation, but you also said something that piqued my interest. You were looking into international models for
Mm.
orthopedic education. I
Yep.
wanted to see if there are any of the most compelling models that you found. Especially, I read a lot in the New England Journal and other places about Australia and Germany
Yep.
specifically, and
Yep.
the public-private partnerships that they forge. I'm
Yep.
really interested in health policy. I'd be curious to see what your most interesting takes are from those areas.
So, yep. So I actually thought you were going to say Australia and Canada because when you're talking about competency-based ed, those are the things that come up. And you may not know this. I have the entire competency-based education movement in Canada was started by a surgeon. He's a general surgeon. But interestingly, the first specialty in Canada at a academic institution, single institution, to try out the competency-based education was the orthopedic specialty, ortho. And I said, okay, sorry, this might be somewhat a rude question, but how did you get the, how did that happen exactly? And he simply said, it was lovely. He said, well, that's pretty easy. They were the only folks that really cared and would step up to try.
Hmm.
And I thought, wow, that's pretty cool. And I think haven't personally been to Australia, although the AOA keynote speaker last year was an Australian, and I certainly have a lot of experience. The Australian system is the other system, and I'm particularly interested in their work with having people do a year or two of unsupervised practice, still part of their training program. So you finish your training, then you go out and do some sort of um, work as an attending, but with backup. And then you take your boards and move on. I think that's an interesting model. And I wonder about that. Germany, I agree with you, and I don't know enough about it. And the other place is Denmark, believe it or not. So a lot of the competency-based work is done by a guy named Oli Tenkate, and I've had the good fortune to do some work with him, and that's where a lot of this idea comes from. But I don't understand the system there well enough. I do have a family-ish member, not blood relative, but product of a relationship, a rotary relationship actually, where the youngster my age finished and went on, and he became a neurosurgeon much faster than I became an orthopedic surgeon. Like he'd been in practice for a whole bunch of years before I even finished residency. So their whole system is different, and I'd like to understand that.
Mhm.
I also recognize, however, having a business background, the European system is nothing like the US system. Similarly, Canada is not like us either. As I'm in Vermont, I'm practically Canada, and it's two it's very, very different worlds. So we have to be a little bit careful saying, well, let's try this cool thing from Australia in the US. You have to respect what we do too in our own system. And as I've said, I think probably 3 times by now, I'm a little worried about where our own system is going. So,
Yeah. You know, I was also thinking too, kind of moving from the systems to the individual level again.
hmm,
When you're talking about how residents, I remember you used the word self-directed learning.
self-directed. Hmm.
And you were saying that that's kind of the crown jewel value of a good resident. And in medical school, it's almost like discipline and obedience and just figure out what you're trying to do and follow along with the team and try to. So self-directed learning is a much
Interesting that
more
you Say that.
Interesting. It's it's almost like you become a bit more of an autodidact instead
Mhm.
of a, collaborator or a follower on a team. You become an autodidact. You're training to become a self, an independent entity. Now, in
In
attending hood, I wanted to know, once these residents
uh,
graduate,
uh,
what's the name of the game in attending hood?
well, so let me give you an example just to think about.
Sure.
Um, and in full disclosure, this was the topic of my master's. So, um, you know what M&M conference is, right?
Yes.
Yep. How many M&Ms have you been to now, roughly, in your life so far?
10,
Oh yeah, at
about.
least.
Yeah.
Okay. And we start in medical school every month in residency for 5 years,
Mhm.
right? Except summers if you're us, whatever. Um, what do you think? So, and M&M's is something that it's the wearing of the hair shirt, right? It's taking responsibility for something that's gone bad in a supportive environment where you can get feedback, whether you're better or worse. And the culture plays a big role there, to be fair. So this was the topic that I wanted to look at directly. What do you think? Let's assume, let's just, I don't know these numbers, but let's assume that 80% of chief residents go out into a private practice model or a private-demic model, not a true on University of Yale, University of Vermont,
Oh,
whatever.
probably
What do you
90%.
think they experience for Eminem?
90%?
Well, I'm just, I that's a
Oh,
look, whatever number. I shouldn't have thrown out a number. I actually don't know what percentage of orthopedic grads these days go into stay in academics. But I don't think it's more than 30% or
maybe.
40%. So
Yeah.
let's stay there. We'll split the difference. 50 foot. So let's just say 50% of your current class is heading out into private practice, or 50% of my grads of it the last 20 years have gone into private practice. What, you know, what do you think they experience for M&M?
You're right. Well, I'll tell you what my dad experienced. I mean, he was
Okay.
a surgeon and he was assigned by a senior surgeon out of residency to um, work, and the senior surgeon put him in the kind of free clinic place, like not
Yep.
free, but so he was doing all the work on the patients with multiple comorbidities and really
Yep.
horrible outcomes. So he got a horrible outcome and he had to drive an hour away every, week just to check up on that patient. And the attending was reaming him
Hmm.
for having this, even though it wasn't his fault. And if these patients had, a better, and the attending was comparing himself against him with a different patient population. So
Correct.
I might say that it's a lot more hierarchical and almost unfair in a way because you're entering a place where it's not supposed to be fair and it's more like everyone out for themselves than
I think I
academics,
think
which
that
is more
I think
collaborative.
that exists. That's actually, and I think that's a great point. But I think there's another point too. Let's put our hats on a different way. Let's say we're in a hospital and you've got three different private practices that make up the orthopedic component. And so M&M at that point is to the degree that is that really a safe space, right? If you're presenting your complications to your competition in a way. And I had never, so one of my interviewees brought that up and I thought, huh, I've never even thought about that.
Hmm.
Does M&M even occur at all? We just, I think in academics and residency particularly, there's some things that we think of as just what we do. Grand rounds. We do grand rounds. We do visiting professorships. We do M&M, you know. But what is the world that we're sending folks out into? You know, does your program have a business of medicine curriculum, for example? We do. We're working on revamping it because it's a little old. But, do we even understand what our graduates need from a non-science, non-medical knowledge, non-technical skill perspective?
Hmm.
And M&M is just one of those places because I think we make assumptions because that's our life, right? That's
Well,
for
what's the
for
solution? It seems like the
Uh,
incentives are
I,
misaligned.
yeah, well, I think the solution is to use folks who are out there in the trenches and figure out what their life is really like.
Mm.
So that and I think, certainly the academy is working to do that. Um, the there's so many great orthopedic specialty groups. The sports guys are trying to do that. The spine guys, as I mentioned, we're a little hard at spine because we cross so many specialties. But you know, there are really, really bright, great leaders in the subspecialty groups who I hope are working to try to understand this, because that information should come back to us as program directors
Mm.
to try to help understand how we position our grads to not only have the basic competencies and the general skills, which is where I started this conversation, but also be able to thrive. So there's survive and then there's thrive.
You know, one of
I
the
like the thrive
other
idea.
thrive a little better than survive. One of the other one of the other people who guests on this podcast was Dr. Seth Leopold, who's the
Yeah,
editor-in-chief of Core.
core.
And
Mhm.
for our viewers, that's clinical orthopedics and related research. And he and I actually maintained a collaboration after this interview where he spoke with me about the challenge of reaching out to private practice folks through Core. And he said specifically, how do you even get the contacts of these people? Because AAOS won't share that. They want
Yep,
their own thing. And
yep,
so you can't really contact them through Core. And he wants something like correlations, which used to exist, which used to kind of be a reach out, try to reach out to private practice folks. Didn't work. People thought it was junk mail, spam mail. How do you bridge the academic private practice gap when people are telling him at conferences, what do you know about the real world? You're just an academics. And he was like, what do you know about academics? And so there's this divide that kind of this rift that grows as people navigate their careers. And I was wondering how you might find academics might enter that space and present those interesting ideas that you have on M&Ms and all these other amazing approaches that could improve orthopedic care nationwide.
well, so I've showed you my hand in terms of three of my favorite things. One is technical skill. How do we become masters? That's a PhD. I'm not doing that degree. But the second being, how does our system, using M&M as an example of a reflection of the culture of a system, how does that inform the how people then are in as attendings? But really, the place that I think there's the most potential, and Dr. Leopold and I have talked about this, is wellness. And because I, in some studies, Tate Shanafeld's original studies found that actually being in an academic community may actually be somewhat more protective if done well. We are an organism in a way in academics. I have 33 faculty, and to some degree, I can easily contact all of them. If you gave me the challenge, I could probably get every one of them on the phone in the next 6 hours if I worked hard enough. Um, as opposed to the larger world of orthopedics, which Seth is absolutely right. How do you reach those folks? And how do you find something that everyone cares about other than the financial business, that side of it? Personally, I think it's burnout. And by I don't mean burnout as a catchphrase. I mean really, truly struggling to find the joy in orthopedic surgery that all brought us here in the first place.
Mhm.
I have worked with that at several platforms nationally in, but I don't think that's just education. I think that's not just our world in academics. I think that might be one of the places we could make some traction. But that being said, right now, given the turmoil right now, I mean, you know, I
Yeah.
don't think, the art of it is having a tool that works. And I'm working with a thing called the flourishing index to see if that is something that is actionable enough to speak to us as surgeons. Um, but because, you can take a Maslow test and it tells you you're burnt out, but that doesn't help you.
Mhm.
You need the problem is you need support, you need contact, you need connection to help you feel well enough to be self-driven
Mhm.
and therefore put yourself out there to take endlessly good care of patients at all hours of the night in all places in the world, right?
In your words, thriving, not surviving.
Thriving, not surviving.
Yes,
Yeah, I
absolutely.
think I think somebody needs to figure that piece out because I think the Thrive tool or something, but Seth is absolutely right. Trying to reach folks is difficult. And now, what, is it? I belong to four big specialty institution, four big specialty memberships. They all charge me lots of money to belong. It's not only that, how am I going to get to four meetings a year with everything else? And I'm not in private practice, you know. So I can only imagine what's out there. And I hope I mention the academy only because I think they probably have the broadest reach into the field as a whole. But you're right. You can't, if you want to study it, do a scientific effort, it's very hard. I will put one plug in for anybody who's a program director, which is a while, I don't know, 7 or 8 years ago, the Council of Orthopedic Educators Research Group was founded. It was founded with the magnificent seven program directors at the time. We just hit 104.
Wow.
And if you think about it, we're starting to get to a point where if you can bring enough people together, you can start to get information that really might help
Mhm.
with understanding some of these bigger sticky issues.
Mhm.
I think AOA Cord, for example, signaling in and selecting residents,
Mhm.
that's obviously on my mind because that's what I've been doing.
Mhm.
How do we help the people find the best program, and how do we help programs find the best fit? It's a match after all, right?
Yeah.
I mean, there's so many things where just understanding big numbers, not 15% of the population, but 70% of the population
Mhm.
would be really, really helpful. And
Yes.
so that's in my, if I had a wish list, it would be a way to have that done without adding burden and getting 42. I'm now going to get 42 surveys in my inbox.
Oh my
No.
goodness. It's just more and more paperwork. Yeah. No, no.
Exactly. I was good. I took 2 weeks off over the holidays and I opened my inbox today and I went, oh my God, it's going to
Oh
take
my
me forever.
goodness. Oh, that's hundreds,
Awful.
thousands.
Talk about burnout.
Wow. Okay. Well, thank you so much. I wanted to kind of give you one more platform here for
Okay,
speaking to trainees on the call.
great.
Anyone who's listening who's either a medical student, like a third or fourth year, or a resident, what advice do you have for them?
Uh, third and fourth. So let me go by generations. Okay. So I'm fond of saying we really have four generations here. We have five, but before medical school, I just don't know a whole lot about. So starting with our youngest folks who are interested in the field, that I have two pieces of advice. One is very early on, and I mean like the minute you hit campus, find someone who can help you navigate all of the specialties to the point that you understand what it takes to be competitive for anything. Because orthopedics in this day and age is still absolutely one of those things.
Mhm.
And as I tell any MS1 that shows up in my office, you don't know, you haven't even, you don't know yet what you want to do. I always ask them what they would do other than orthopedics because I'm always interested in that answer. But if you are positioned to be competitive for orthopedics, you're competitive for anything and everything because we are that way. We are not that way because we are the most outstanding specialty on the planet, although we like to think we are. We're that way because we have 800 and some odd spots and at least three people for every one of those spots interested. So for folks interested it's a pain, but there's nothing worse than having somebody who's truly interested and would be truly great, but can't make it through the crazy process by which people get interviews. So that's my advice for medical students. And find somebody. If you don't have somebody, find me and we'll find you somebody because you need somebody to help you navigate that kind of stuff. The second is residents, which are my fond, that's what I do. That's what I love. And I'm going to, by the way, put fellows in the young attending group. Okay. Fellows are not residents. Residents are residents. Assuming that you have picked a residency that is going to push you, which is always my advice. You don't pick the one that you think would be great fit. You pick the one that's going to push the things that are not great and make them better. Then I think my advice is to not be afraid to open the door, your program director's door, somebody's door, an ombudsman, if you can't talk to the program director, and say, hey, you know what? We have a problem. Can I talk to you about that confidentiality? And because things, good and bad, good things get even better, and bad things can be helped when they're caught early. But when you get too far along, you as a chief resident can't fix that thing that's been driving you crazy since you were a PGY2. So get help early. And that's, in my mind, that's what a program director's prime job is.
Mhm.
For fellows and young faculty, mentorship is key. So it's not 10,000. It's deliberate practice as deliberate practice was defined by Erickson. It's working with someone who can help you maximize the time you spend, which just so happens to be somewhere in the neighborhood of 10,000 hours. But it's not putting in the time, it's putting in the time correct in a way that is most beneficial to you. And that working with a mentor, whether in your specialty or just anywhere, I think that's really, really key. And I hope that folks in private practice world have that same opportunity or can at least reach back to their fellowship, which is what I did very much for that. And then my young attending folks, I think we learn to be excellent educators early and it's hard because that's also the time we're learning to be excellent surgeons. So that's a lot of pressure in the first 10 years of life as an attending surgeon, as an educator. But it will pay off in the end.
Yes.
So those are my generational advices. And then as for those of us who have gray hair and vice whatever roles, I have no idea.
Well, it's
Lord
very
help us
clear
is
you're
all I'm going to
speaking from a
say.
position of experience. So, yes. No, of course. And I appreciate this. This is very, very enlightening conversation here. And I hope that our medical students that have watched this, our trainees, our young attendings have learned so much from this, so much from you. And that's really why I do this podcast. I want to,
So I'm going to then take my priority and ask you a question back,
sure.
which is, there has certainly been an effort to do things like the standardized application process, the ORIN network, those sorts of things. Given the fact that I'm not sure it's any better, so I'll show my hand to say that, but what do you think we need? What can we do to help
Hmm.
folks
Um,
in the 2 years before and first 2 years of orthopedic training?
I think clarify the expectations from the program standpoint, not from the orthopedic standpoint. And
Okay.
what I mean by that is what I've learned speaking to a lot of program directors is that their goalposts are at opposite ends of the field. A lot of the times when I focused on a specific kind of research or some kind of something, a different program director says, "Oh, that's not the kind that, our residents typically get." Or, I've had a program director say, "Oh, I love your work. I love this. If you ever want to apply to our position, you have a spot open to be an AI here. Just text me." And another program director says, "Oh, your resume is not a good fit at all for our program, and this isn't
Yeah.
at all what we're looking for. And we're looking for, for instance, I do epidemiologic studies on musculoskeletal disorders. And, this program director would say, like, you need a study on how many Newton meters of torque you need for a spine screw. But then another program director says, your studies are just inspiring, amazing. And so,
Well,
maybe to
and all program
clarify.
directors now say we're not even looking at you unless you're published, which means you have to have studies of something,
Yes,
right?
yes.
So
Well,
there's that whole other system side of things too.
of course, of course. And kind of approaching that, I did understand that, research is very important, and that's what I prioritized. But then there's so many other unspoken things that
Yeah,
various program directors are looking for, and to clarify that for your own program and for your own
yeah,
students really enlightens the conversation and helps the student work from day one toward the kind of resident you want them to be. And I
yeah.
think
I
that's
think
that's
that's
a really
true. I
exciting.
I think that the variation is actually good because there, there might be a pitfall would be all the residency programs look the same and the fit is the same everywhere. I mean, that would be terrible. Okay,
Yes.
that's the five major residency programs, training all programs, all residents ever going into orthopedics thing. So I actually take a little heart from what you said in that people are being transparent enough to give you information. That's a good thing. That I'm not sure I would say that has always existed. So I'm actually somewhat encouraged to say that. Uh, we've certainly tried to create Orin to give people ideas. I worry that certainly in COVID, we learned that not having face-to-face time with acting internships was not easy at all. Our medical school here still restricts the number of AIs that folks can go on, and that's a bit of a challenge. But on the other hand, it's a little ridiculous that orthopedic folks are doing 3, 4, 5 ways as well. So there's got to be a balance there.
Yes.
But what I took from that I like, I understand your frustration, but what I took that I like is that people are willing
Mhm.
to give you ideas and feedback. There is no one way to be an excellent orthopedic applicant.
Mhm.
And we had so many orthopedic that we had so much, 400 plus applications if you read them all, as we do here. Um, you gotta at some point you gotta find something that says, "Oh, Cameron's pretty cool. I want to talk to Cameron." Right? But that may be very different for me than it is for another program.
Of course, of course.
I
And I,
believe.
I love that transparency, and I really appreciate that. And it really teaches me about the variation in all these programs. And of
Yep.
course, I mean, if you have hegemony like over the entire nation of orthopedic surgeons, just everyone has to do this one thing. Of course, of course.
Well, I like to argue, and I have argued that we have different kind of diversity in orthopedics, but you do recognize you're talking to one of the few here. As
Yes,
a
yes,
blonde female who trained in the 90s, and we were kind of a small crowd there,
of course.
and that's changing too. So
Yes.
I do think that your generation has a lot to offer, and there are a lot of changes coming.
Hmm.
And as we see younger program directors take over, I think the specialty is going to work that way too. We don't want to lose what's good,
Hmm.
absolutely. But until somebody gives us more residency training spots, which I don't think is going to happen anytime soon, the arms race is going to, as I think Dr. Leopold may have coined that term, the arms race of trying to get a job is going to be a challenge. And for residents listening, help the youngster that's coming up behind, because any resident has been able to come through that system happy, or whether they're over the moon with their choice or just happy is another question, but that's a personal thing.
Yes.
It's if you can just navigate the crazy system of getting a residency spot in the first place, then you've come a long, long way. And
Yes.
that is the challenge. And we get it, we understand it, but it's a numbers game. And things, the application, trying to sort through applications these days is not an easy thing to figure out who everybody is
Yes.
to
Of
try to
course.
find that fit.
Of
So
course. Of
good for
course.
you for going out and asking.
No, no, I really appreciate it. Very refreshing takes today. Thank you very much for sharing all
My
this.
pleasure.
And, you know, yeah, if there are any questions, feel free, to our audience, feel free to reach out to me, I guess, and then I can,
No,
try to.
it, you know what? It's, I am, I have a email for this kind of thing. I don't check it all the time because I use my academic one more. But if anyone wants to reach out, it's elizabeth.ames, AMES, at uvmhealth.org. That's our hospital system. I try to at least get on there once a week. So don't feel like you're gonna interrupt me in a bad time, but if anyone needs information or questions, sometimes it's just a matter of saying, help, I'm at a program, I don't have any orthopedic surgeons.
Mhm.
Sometimes it's, I'm an MS1 and I'm too shy, I don't know what to do,
And if you've
whatever.
reached this point of the interview, you're clearly interested. So,
I agree. And that's why I make the offer at the end, not at the beginning. Not my first rodeo, my friend.
oh my goodness. Okay. Well,
Okay,
thank you very much again. Thank you
my
for
pleasure.
joining. Yeah,
Take care.
yes. See you
Appreciate
soon.
it.
Thank you.
Bye.
Bye-bye.